distinguished guests, ladies and gentlemen. Good evening and a warm welcome to the Dr. C.G. Uragoda History of Medicine Lecture 2023. Please rise as the ceremonial procession now enters the hall. Ladies and gentlemen, once again, a very good evening and a warm welcome to the Dr. C.G. Uragoda History of Medicine Lecture 2023, organized by Sri Lanka Medical Association. As we will now commence the proceedings of this evening, please rise for the national anthem.
Sri Lanka, Namo, Namo, Namo.
Ladies and gentlemen, in keeping with tradition, next in the agenda is lighting of the oil lamp. Will the following dignitaries please come forward to partake in this moment? The President of Sri Lanka Medical Association, Dr. Vinya Ariratna. The Secretary of Sri Lanka Medical Association, Dr. Sajith Idrisinghe, and the President-elect of Sri Lanka Medical Association, Dr. Ananda Vijayvikrama. One of the family members of the orator tonight, Dr. Kapila Jayaratne, and the orator himself, Dr. Kapila Jayaratne. The Navy Command of Sri Lanka Navy, Vice Admiral Priyantha Pereira, and the Director General Health Services, Dr. Asela Gunawardena, Additional Secretary, Ministry of Health, Dr. Lakshmi Somatunga, Additional Secretary, Ministry of Health, Dr. Sunil D. Alvis, and the President of Sri Lanka College of Obstetricians and Gynecologists, Dr. Lakshman Sena Nayak. And also representing one of the past presidents of Sri Lanka Medical Association, Professor Malik Fernando. As well as one of the family members of Dr. C.G. Uragoda. Thank you, ladies and gentlemen. You may now take your seats. The President of Sri Lanka Medical Association, Dr. Vinya Ariratna, and the orator tonight, Dr. Kapila Jayaratne, will now proceed to the head table. Ladies and gentlemen, the orator tonight is a familiar face to all of us at the SLMA, and Dr. Vinya Ariratna, the President of Sri Lanka Medical Association, will now introduce the orator. Over to you, sir.
Good evening. Good evening. Chairman and members of the Board of Trustees of the Sri Lanka Medical Association, past presidents, President-elect Dr. Ananda Vijayvikrama, Secretary and the Council members and the members of Sri Lanka Medical Association, family members of late Dr. C.G. Uragoda, distinguished invitees, ladies and gentlemen. It's with great pleasure and honor that I welcome all of you today, this evening, to the C.G. Uragoda Oration on the History of Medicine 2023 on the topic, Counting and Reviewing Maternal Deaths, a Journey Towards Supremacy, to be delivered by Dr. Kapila Jayaratne. And it's my great pleasure to introduce Dr. Kapila Jayaratne this evening. Imbulana Liyanage Kapilasiri Jayaratne was born in 1967. Young Kapila went to Gotami Vidyalaya Gampaha for his primary education. He was a grade 5 scholar and entered Royal College in 1979. He achieved the All-Ireland second place in O-level examination in 1983 and won the Lawrence Scholarship. Kapila entered Colombo Medical Faculty in 1987-88. He obtained second lower classes in second, third and final MBBS and graduated in 1995. Dr. Jayaratna started his medical professional career with the internship at Sri Jayawardenepura Teaching Hospital under Dr. Felix Nanayakara, consultant physician, and Dr. D.D. Ranasinghe, consultant surgeon. Then he worked at District Hospital Dompe for 5 years, 1997 to 2002. In 2002, he was appointed as the Medical Officer of Health, Biyagama. Kapila obtained his postgraduate qualifications, Masters in Community Medicine in 2005, Diploma in Child Health in 2007, Doctor of Medicine in Community Medicine in 2007 from the Postgraduate Institute of Medicine, University of Colombo. He did his MSc dissertation under the supervision of Professor Vasantha Gunatunga. Dr. Jayaratna ranked first in the MD Community Medicine Part 1 examination. He did his registrarship at the Faculty of Medicine, Colombo, under the supervision of Professor Dulita Fernando. For his MD thesis, he studied ergonomic factors in school classrooms and translated the research findings to general public and policymakers for utilization and modeled and ergonomically designed healthy school bag at the national level in 2011 to benefit 4.8 million school children in the country. Dr. Jayaratna has his post-doctoral training as a visiting fellow at the School of Population Health, University of Melbourne in 2008-2009 under Professor David Dunt. After board certification as a consultant community physician in 2009, he assumed the duty as the National Program Manager for Maternal and Child Morbidity and Mortality, Child Morbidity and Mortality Surveillance at the Family Health Bureau, Ministry of Health. As the focal point for maternal death surveillance and response system, he improved the mechanism with the addition of number of quality dimensions. He went from district to district all throughout the country with a team of experts reviewing the maternal deaths for 12 years. He revived the maternal death surveillance system to be recognized as a quality program even at the international level. Today, the other country teams also visit Sri Lanka to study our surveillance system as a role model. You will hear some of his experiences today. He pioneered in establishing a number of national systems in maternal and child health. Dr. Jayaratna initiated maternal near-miss inquiry system countrywide in 2016. He launched a psychological autopsy tool with the contribution of psychiatrists to review the maternal suicides objectively at field level. He started a comprehensive feto-infant mortality surveillance system covering the entire country in January 2016. Each and every stillbirth and infant death is counted and reviewed with regard to any service deficiencies in this project. He took a key role in facilitating stillbirth registration with the civil death registration system. Dr. Jayaratna promoted conducting pathological postmortems on perinatal deaths. He is the national focal points for birth defect surveillance. Kapila introduced a national birth defects surveillance system at full scale throughout the country in 2020. A team led by him also works in the area of prevention of childhood injuries through maternal and child health networks. Dr. Jayaratna is a member of several technical advisory committees on family health, National Medicinal Regulatory Authority, tuberculosis and childhood cancer. Dr. Jayaratna played a distinct role in the development of the National MCH Policy, MCH Strategic Plan and National Action Plan on Birth Defect Surveillance, Prevention and Control. He has also contributed to several WHO documents, Child Environmental Health Units in 2010, and evaluating quality of care for severe pregnancy complications, the WHO near-miss approach for maternal health in 2012, implementation of maternal death review in 5 countries in Southeast Asian region of the World Health Organization in 2014, and WHO application of the International Classification of Disease ICD-10 to deaths during the perinatal period ICD-PM 2016. Dr. Jayaratna also implements the program of integrated management of childhood illnesses at national level. He contributes immensely to the professional development of fellow members. He trains field healthcare teams. He is a visiting lecturer at Postgraduate Institute of Medicine, University of Colombo for several specialties, and he also serves as an examiner at PGIM. Dr. Jayaratna as a researcher have conducted several epidemiological research with nearly 45 peer-reviewed scientific publications with a H index of 20 with 2,800 citations, and he was the principal investigator for number of WHO countrywide surveys. Dr. Jayaratna is also the country investigator for the study in Zika-related microcephaly in Sub-Saharan Africa and Asia conducted by the Pasteur Institute, France. Dr. Jayaratna is involved with several professional organizations, including the SLMA, and held the post of council member, assistant secretary, and secretary. At present, he is the chairperson of the expert committee on birth defects of SLMA, and he was a council member and treasurer of the community physicians of Sri Lanka. He was the president of Perinatal Society of Sri Lanka in 2017-18. At global level, Dr. Jayaratna has served as the co-chair, member of Technical Committee on Ergonomics for Children in Educational Environments of International Ergonomics Association in 2011 to 2013. Currently, he is a member of 2 WHO expert technical advisory groups on maternal mortality measurements in birth defects. He has won President's Awards for scientific publications for several years and National Research Council Merit Award for Scientific Publications. He was awarded the Donald Court Visiting Fellowship of the Royal College of Pediatrics and Child Health in 2008. He has done several orations of the prestigious SLMA oration in 2010 and also AVKVA De Silva oration of the College of Community Physicians of Sri Lanka in 2015. This is his 4th SLMA oration. Apart from his contributions highlighted above, the community development, and he interacts with the society in transfer of knowledge. He's a media person. Kapila always utilizes print and electronic media to disseminate relevant family health data to communities. Kapila is also popularly known as CapJ amongst his batchmates and fellow medical students. He is well known for preparing short notes and MCQs for peer students. A unique feature of Dr. Jayaratna is that he always drives for results. He accepts accountability for work tasks assigned to him. He takes personal ownership and accountability to meet deadlines and achieve agreed results, and has personal organization to do so. Not only professional capabilities, Kapila also possesses some artistic talents. He played several roles in dramas and wrote many poems. Despite a tight schedule in working with professional involvements, career development, and general practice, he is committed to and enjoys his family life with his wife Kishani and 2 children, Enuri and Tisuka. Dr. Jayaratna is an energetic, multi-talented, multifaceted professional, and I am deeply honored to invite Dr. Jayaratna to deliver the Deshabandu Dr. C.G. Uragoda Oration on the History of Medicine 2013. Thank you.
Thank you, sir. And now, the President of Sri Lanka Medical Association, Dr. Vinya Ariratna, will be awarding the medal for Dr. C.G. Uragoda to the orator tonight, Dr. Kapila Jayaratna.
Please look at this picture. I am taking you to 2645 years backward. We all know about Mahamaya Devi's remarkable conception, faultless gestation, and birth of Prince Siddhartha. The history says that Mahamaya Devi delivered Prince Siddhartha in the Lumbini Grove on her way to visit her parents' palace, which may suggest a precipitous labor. Although the chronicles describe a blissful pregnancy, she died a week after childbirth. It is unclear if this was due to hemorrhage, sepsis, or any other postpartum complication. Global historical records also depict a few other pregnancy-related deaths known to be of unique women. Mumtaz Mahal, wife of the Mughal Emperor Shah Jahan; Julia, daughter of Julius Caesar; Charlotte Bonaparte, Napoleon Bonaparte's niece; and Anna of Austria, the Queen of Spain. But while we know of a famous women who died in childbirth, we don't know the names of millions of other women who died of causes related to pregnancy and childbirth. Even today, after substantial improvements in maternal care across the globe, nearly 295,000 women die every year from complications in pregnancy and childbirth. Their tragic stories remain unheard, and many of these deaths are often uncounted. The status of two lives in one body confers a pregnant woman to be considered the precious life in any civilized society. Death of a pregnant woman is a huge tragedy for the families and is completely at odds with the joyful anticipation of a new arrival. A woman dying while pregnant or within 42 days after termination of pregnancy due to direct or indirect causes is considered a maternal death. President, members of the Council, members of the Sri Lanka Medical Association, distinguished invitees, friends, ladies and gentlemen. For me, frustrated with hearing tragic stories of dead women almost every morning as the National Program Manager for Maternal Death Surveillance for 12 years, I refocus into a challenge. I thought of peeping into the past in search of milestones of counting, reviewing and responding to maternal deaths in Sri Lanka. Quite refreshingly, I found an abundance of new stories about maternal mortality in the country. Many of these point to a more positive, wholesome view of the evolution and the success of a surveillance and response system of a low and middle income country. I am greatly honored and indeed tremendously privileged to see you all in this distinguished audience on our invitation and for me to deliver this prestigious oration in recognition of Deshabandu, Dr. C.G. Uragoda. Dr. C.G. Uragoda, MBBS Ceylon, MD Ceylon, Honorary DSc Colombo, FRCP Edinburgh, and FRCP Glasgow, is a physician, a distinguished professional on occupational test disorders, a legendary author, an unmatchable historian, and a well-known ecologist. Christopher Gundapala Uragoda was born in 1928 as the third and youngest son of surveyor NFDS Uragoda and Mrs. Lena Uragoda in Hikkaduwa. Following his early secondary education at Richmond College and Mahinda College Galle, he completed higher studies at Ananda College, Colombo, to enter the Colombo Medical College. He graduated in 1953, and in 1959 he proceeded to the UK to specialize in respiratory diseases. On his return in 1962, he was appointed as physician in charge of the chest clinic and was transferred to the chest clinic in Colombo in 1973. With his high academic qualifications, Dr. Uragoda is known for his clinical and research work in occupational lung disease in people working in the tea, coffee, activated charcoal, graphite, coir, kapok, and the spice industry. He was a distinguished scientific writer and a historian with a proven track record of no mean repute. These two traits have combined to produce many scholarly work, some of which have become the gold standards of the history of medicine in Sri Lanka. Apart from numerous research papers, especially on chest diseases, he has also authored many books on the history of medicine in Sri Lanka. His maiden book, A History of Medicine in Sri Lanka, from the earliest times to 1948, was authored by him to mark the centenary of the Sri Lanka Medical Association in 1987. Trespassing the boundaries of medicine, he has also authored many books on the history of Sri Lanka and wildlife. In 2005, the government of Sri Lanka conferred on him the title Deshabandu. He was a past president of the Sri Lanka Medical Association, Ceylon College of Physicians, and the Royal Asiatic Society of Sri Lanka. He served as the joint editor of the Ceylon Medical Journal. In recognition of his lasting contribution to documenting the history of medicine in Sri Lanka, the SLMA History of Medicine lecture it is delivered every year on the 26th of February, the date of formation of the SLMA. After his demise, the title was changed to the Deshabandu Dr. C.G. Uragoda History of Medicine Oration in 2021. I was most fortunate to be selected to deliver that lecture this year. I thank the President, the Secretary and the Oration Committee for recognizing me, a public health physician working in the field of maternal and child health, to be honored with this prestigious oration. We did a search for available journal articles, reports, and other publications relevant to maternal death surveillance by conducting an electronic search. We visited SLMA Library and National Archives to hand search documents and articles. We also conducted interviews with purposefully selected key stakeholders who have been involved in the MDSR process. I am so happy that many of them are in the audience both physically and virtually. In the initiation and development of maternal care service delivery in the country, a key milestone was the Colombo Medical School, which was opened by the then Governor Sir Hercule Robinson in 1870. 1879 marks the start of institutional maternal care at the Visoisa line in home at Ural. Sir Charles Henry Visoisa became the first person in Asia to gift a maternity hospital. In addition to providing clinical services for women's health, the hospital started and provided training in midwifery for midwives in 1909, nurses 1916, and obstetrics and gynecology for medical students 1950. The use of anesthesia in obstetrics was first reported in 1889 when Dr. Limbruggen at Panadura Hospital did manipulation under chloroform in 2 cases of difficult labor due to dorso-anterior right arm presentation. In 1905, the first caesarean section operation in Sri Lanka was performed at DMH. Field maternity and childcare services were initiated by Colombo municipality during the period 1902 to 1906. The Soisa line in home commenced the first antenatal clinic in Asia in 1921. An organized effort to provide maternal and child health services commenced with the introduction of the health unit system in 1926, Kalutara being the first health unit established with a medical officer of health, MOH. In 1953, the Family Planning Association of Sri Lanka was established. The government accepted family planning as a national policy in 1965. A separate division was established in 1968 within the Ministry of Health to implement the MCH program throughout the country. This was initially designated as Maternal and Child Health Bureau and was later redesignated as the Family Health Bureau. At first glance, identifying a maternal death might be seen as easy. However, unlike identifying a male or female death or deaths due to a specific cause, identifying a dead woman, whether she was pregnant or within 42 days after termination of delivery at the time of death is not always easy. The maternal mortality ratio is the annual number of maternal deaths per 100,000 live births per year. This indicator reflects the capacity of health systems to effectively prevent and address the complications occurring during pregnancy and childbirth. If a country cannot provide adequate care, at least to its pregnant women, such a healthcare delivery system is not accepted as performing well. Availability of quality maternal mortality data is therefore instrumental in improving quality of care and monitoring the progress of reduction of such death. In Ceylon, the registration of births, deaths and marriages was initiated under Dutch rule during 1640 to 1798. Catholic Church had several records, including birth and marriage registers, which were separately maintained for each caste in the local parish. Under British colonial rule, voluntary registration of births and deaths covering all districts was started in the year 1847 under the Ordinance number 6 and number 8. The voluntary civil registration of births and deaths was transformed into a compulsory legislative requirement in 1897. Sri Lanka started counting maternal deaths far back in the year 1881. The available evidence shows the first reported maternal mortality ratio of 21.7 per 1,000 births of the country with 1,623 maternal deaths in the year 1881. This is as reported by Dr. Rodrigo. The original source could not be located. The civil birth and death registration system facilitated the capture of maternal deaths and the computing of maternal mortality indices. The annual report of the Registrar General of Ceylon on vital statistics was the official source of maternal mortality statistics. The annual report of the Director of Health Services was another source to extract maternal morbidity and mortality listed under all diseases and deaths at all government institutions. Starting from the year 1901, the Ceylon Civil Medical Department officially published maternal mortality data in the report of the Principal Civil Medical Officer and Inspector General of Hospitals each year. The 1901 report includes a detailed annual report from the Medical Superintendent of the Disoisa line in home by Dr. M. Sinnathambi. This gives details of 4 maternal deaths. From 1900 till 1957, key health service data are available from the reports of the Director of Health Services. This 1918 report shows 1,727 cases of puerperal sepsis. Publication of maternal mortality statistics continued, although the nomenclature of the head and the institution changed from time to time. The annual health bulletin published by the Ministry of Health provides comprehensive maternal mortality data from 1980. This is the latest version with a full picture of the maternal mortality in the country. An analysis of 1,004 maternal deaths that occurred at the De Soysa line in home during the period 1933 to 1938 was presented at the induction of the President of the Ceylon branch of the British Medical Association in 1939. There were 466 deaths directly due to childbearing and 538 associated deaths. The leading causes were ankylostomachitis, malaria, eclampsia, and puerperal sepsis. Dr. G.A.W. Wickramasuriya lamented, "Are we anywhere near this ideal?" The answer would be most emphatically no. I feel sure that our present mortality rates would have been considered excessive even in the pre-antiseptic and pre-anesthetic eras of nearly a century ago. Today, we have earned the unenviable reputation of having one of the largest maternal and infant mortality rates in the world. I append below a statement from the Registrar General showing the relative position of Ceylon in regard to maternal mortality compared with some other countries. This comparison showed that the rate for Ceylon, 21.1 per 1,000 live births, was one of the highest in the world. Details of maternal deaths for the period 1933 to 48 were also included in an analysis of the vital statistics of the country by Columbine in 1950. Between 1933 and 1946, the death rate from puerperal infection was approximately half, and this reduction accounted for 75% of the reduction in maternal mortality over the same period. The Ceylon Government Gazette of 1949 gives the maternal mortality of the country as reported by Registrar General. Maternal mortality rate for the year 1947 was 8.2 per 1,000 live births with 2,345 deaths. Dr. P.H. Amarasinghe, consultant obstetrician, in 1962 published a comprehensive analysis of maternal mortality and morbidity from different data sources in the country in Ceylon Medical Journal. It covered yearly trend of maternal mortality from 1921 to 1959 as reported by Registrar General. You can see the number of maternal deaths in this column. A district distribution of maternal deaths with the causes is also given for the year 1958. Leading districts were Colombo 196, Kandy 172, and Kurunegala 107. This article also included the findings of the first national maternal death surveillance conducted by the Ministry of Health. I will be presenting it later. A compilation of maternal mortality data for 101 years was done in the year 1986 by Dr. J.N. Rodrigo, consultant obstetrician and gynecologist, and presented at the Dr. S.L. Navaratnam Memorial Oration. This covered the period from 1881 to 1981 and facilitated compiling national maternal mortality ratio graphs. By end of 1980s, the country had four main systems of reporting the number of maternal deaths. Monthly maternity statistics return H830 from all government hospitals, Registrar General Appeals, Civil Death Registration, Reproductive Health Management Information System RHIMS, and Maternal Death Surveillance. A reproductive health management information system was implemented in 1986 by the Family Health Bureau for monitoring, evaluating and planning of MCH services in Sri Lanka. With this, the public health midwives assigned to each household all over the country were instructed to register all eligible couples. This is the foundation of a solid MCH information system in Sri Lanka. Under RHIMS, all divisional health managers, that is MOHs, send the field quarterly MCH return H509 to the FHB. H509 was a consolidated report based on public health midwives' monthly statement, which includes the number of maternal deaths and the number for which a local death investigation was conducted by the healthcare teams. Al Jazeera described this as registers for life. Despite all three mechanisms were in operation, there was underreporting of the number and consequently the level of maternal mortality. A reproductive age mortality survey, RAMOS, carried out in 1994 to 95 by Dr. Chitramalidi Silva showed that maternal deaths in the western province were 24% underreported. It reported that 67% of the deaths were due to direct obstetric causes and 33% were due to indirect causes. However, with the coverage of the capture of deaths nearing 100%, the MDSR system operated by Family Health Bureau was recognized as the official source of maternal mortality statistics since the year 1996. In the decades of 1970s and 1980s, at the global level, more quality data on infant mortality were increasingly available. In contrast, there had been no equivalent advances in maternal mortality and the burden remained largely hidden. WHO and UNFPA supported studying maternal mortality in developing countries and produced the first guesstimates of the extent of the problem in the year 1985. WHO also published country-level maternal mortality estimates in the year 1991. For Sri Lanka, the report included maternal deaths data from 1970, 150, to 1982, 25 per 100,000 live births, based on civil death registration. One of the stalwart obstetricians of SLCOG, Dr. Lakshman Senanayaka, said, SLCOG pursued that these estimates were not accurate. We were not happy. We wanted to get the accurate figure of maternal mortality for Sri Lanka. This was reflected in SLCOG's journal in 1996, Sri Lanka's maternal mortality, Too Good to Be True. The SLCOG, in collaboration with UNICEF, conducted a landmark study to determine a more accurate estimate of maternal mortality for the year 1996. This study triangulated reproductive age female deaths reported by the civil registration system, deaths reported to maternal death surveillance system of Family Health Bureau, and deaths reported by other sources. The study identified 312 maternal deaths, out of which 199 had been reported to Family Health Bureau. There were 66 deaths that were not included either in death registration or FHB. Two of the contributors, Dr. Lakshman Senanayak and Prasanna Gunasekara, are in this audience today. In the year 1996, in preparation for a World Bank publication on investing in maternal deaths, learning from Malaysia and Sri Lanka, the local consultant team led by Professor Lalini Rajapaksa prepared a maternal mortality database after an intensive review of data sources used in previous studies and reports published by the Registrar General's Department. It produced a national maternal mortality ratio graph based on solid data with time-specific interventions carried out to reduce maternal deaths. Family Health Bureau, the maternal and child health arm of the Ministry of Health, started maintaining a national maternal mortality database from the year 1996. Descriptive maternal mortality data are published in the annual health bulletin of the Ministry of Health. In addition, the annual report of Family Health Bureau has also included a chapter on maternal deaths. Periodic analysis of the country's maternal mortality data for the years 2001 to 2005, 2006 to 2010, and 2011 to 2013 are available at the FHB official website. The analysis for the years 2014 to 2018 has been finalized. Thus, Sri Lanka claims of processing a high-quality maternal mortality database starting from 1881 to date. Reviewing maternal deaths have shown to be a best practice effective in further preventing such deaths and improving the care delivered to pre-pregnant, pregnant, and postpartum women in the country. Each maternal death has a story to tell and can provide implication on practical ways of addressing its causes and determinants. The UK started confidential inquiries into maternal deaths far back in 1952, just 4 years after the inception of NHS. In 2004, the World Health Organization advocated for all countries to establish maternal death surveillance and response systems to help reduce maternal deaths in a landmark publication titled Beyond the Numbers. A maternal death surveillance and response system is a mechanism that includes maternal death identification, reporting, review, and response, and provides the essential information to stimulate and guide actions to prevent future maternal deaths and improve the measurement of maternal mortality. Such a system generates quality data for action. The year 1959 marks revolutionary milestone of the history of systematic surveillance of maternal deaths in Sri Lanka. The annual administration report of the Director of Health Services, Ceylon 1959, clearly states about Matru Saha Bilindu Marana Vimansanaya and elaborates that a maternal death investigation committee was established with an additional director, an obstetrician, and an advisor from the WHO. Specific investigation formats were developed. The official of the maternal care unit of the Department of Health was assigned to formulate a project to review maternal death with the support of the above committee. A pilot project on maternal and neonatal death surveillance was completed in 2 selected divisions by the Director of Health Services. My findings revert the fact that maternal death surveillance in the country was started in 1981, a record that has been eternally highlighted in almost all publications related to MDSR of Sri Lanka. I thank Dr. Lakshman Senanayaka for giving me a clue that I could explore in depth. I am so proud that I could rectify the historical mistake and disclose the correct evidence to the world. The progress of the surveillance mechanism and the actions undertaken have been documented in subsequent annual reports. The 1960 report mentions that the system is underway and the first finding of the leading cause for maternal death as anemia. In the early 1960s, the system of maternal death investigation was further improved with the introduction of the maternal death investigation format. The investigation committee conducted frequent meetings in the year 1962. An expert group conducted a pilot study to ascertain the suitability of the investigation format in selected health regions. The revised format was printed by the government printer and distributed to all health regions. A significant number of maternal deaths were reported using the format. The findings of the first national level surveillance of maternal deaths undertaken by the Maternal Death Investigation Committee of Ministry of Health were published in Ceylon Medical Journal by Dr. P.H. Amarasinghe, consultant obstetrician in 1962. This was based on the questionnaire sent by the chairman of the Maternal Death Investigation Committee to all government hospitals in Ceylon. A detailed analysis of maternal mortality in all the main government hospitals in Ceylon for the year 1960 was available. A high coverage was noted with 24 of the 26 specialist obstetricians and a majority of MOICs of maternity units in district hospitals sending completed data. By 1960, the hospital delivery rate in the country was 55%. A total of 437 deaths were reported in 92,734 deliveries, 361 in specialized hospitals with obstetricians, and 76 deaths in other larger government hospitals, more than 100 beds. The hospital-wise breakdown of maternal deaths found that postpartum hemorrhage, anemia, operative complications as the leading causes of maternal deaths. The format report on maternal deaths, Form 677, has been in place for many years to be completed by MOH and the hospital. Although maternal deaths were investigated, the system was not complete and there were no formal reviews conducted. In hospitals, these deaths were investigated in an ad hoc manner. Sri Lanka initiated national reviews to monitor the coverage of the expanded program on immunization, EPI, from the mid-1980s, 1980s, supported by UNICEF in collaboration with the Ministry of Health. This was an annual review meeting chaired by the Secretary of Health with officials from the Family Health Bureau, Epidemiology Unit, and other relevant stakeholders to report immunization coverage in each MOH division. It was an interactive platform between field health staff and central ministry level staff to identify problems where immunization coverage was low, the reasons for it, and determine the strategies to overcome the problem in a joint effort. This was a time period even at global level, the perception that women's health was relatively under prioritized compared with the high emphasis given to survival, child survival and health. Seated in an EPI review, a thought came to then National Program Officer of UNICEF, Dr. Hiranti Vijayamanna, and she was telling, where is M in MCH? Once again, M was given a backseat. I thought that we should introduce the concept of maternal death audits. I felt a quick method which was practical and easy to put into practice better than setting up a whole new system. If we could piggyback on EPI review system and introduce reporting of maternal deaths per quarter in each MOH division, this could have an impact on reducing preventable maternal deaths. In the same wavelength was a great healthcare administrator who went above and beyond the call of duty, Dr. Deshabandu, then Secretary of Health. Unfortunately, he could not physically participate in this oration. With the concurrence and active involvement of MOH by Dr. Deshabandu, a systematic review of maternal death was included as an appendage to the ongoing national EPI reviews from 1985. Dr. N.W. Vidyasagara was the Director of Family Health Bureau. Reported maternal deaths were reviewed and discussed in detail annually at the national level. The respective health staff, MOH, when relevant even the area public health midwife, head of the institution, obstetrician, MONCH, RDHS and PDHS were called to the Ministry of Health. The Secretary, Ministry of Health, was the chairperson with the Family Health Bureau organizing the reviews. The College of Obstetricians was invited to attend these meetings, including the professorial unit of the Faculty of Medicine, Colombo. This was an individual case review. At the reviews, public health staff presented each maternal death, clinical management was complemented by hospital heads, and cases were analyzed to establish the exact cause of death and to identify the key factors that were responsible for the mother's death according to the 3-delay model. The objective of the reviews was not to find fault but to prevent further deaths by preventing contributory factors. Corrective actions were suggested and some issues were immediately addressed at the meeting. Commenting on the review atmosphere, one of the then divisional managers, Dr. Chandani Galwaduge, remarked, "I think the no name, no blame concept was not 100% practiced. After the review, guilty feeling was always there, but it motivated field staff to work very hard." In 1986, the system was strengthened further by making maternal deaths a notifiable event by issuing a gazette notification by the Ministry of Health. However, even after much efforts, we could not locate the relevant gazette at the National Archives. In the year 1991, circular guidance spelling out the procedures to be followed in the investigation of maternal deaths was issued by the Ministry of Health. This was drafted by Dr. Malini De Silva, then Director, Family Health Bureau, under the instructions of Dr. Joe Fernando. A clear definition of maternal death based on WHO definition was included for the notification of all deaths occurring at hospital or at the field level. The firm grip on the execution of the MDSR by the Ministry of Health was reflected in the circular with the addition of the clause, "A head of an institution who does not investigate a maternal death within 3 days of the death will be called to give explanation why the investigation was not done. Ministry of Health will take a serious note of the lapses on the part of the head of an institution in this regard." In 1992, considering the need for a more organized MDSR system, the Ministry of Health and the WHO Country Office facilitated the visit of Prof. Brian Hibbard, WHO Consultant and Emeritus Professor of Obstetrics and Gynecology, University of Wales, Chairman of the Clinical Subgroup, Central Assessor and Member of the Editorial Board, UK Confidential Inquiry into Maternal Deaths, and Dr. Godfrey Walker, the officer responsible for WHO Maternal Death and Safe Motherhood at WHO, to study the maternal death review system. They highlighted several weaknesses in relation to maternal death notification procedure. A common comment is that maternal death forms are not available, but there seems to be a widespread lack of motivation, possibly because of clinical pressures and priorities, reluctance to expose deficiencies, and failure to pursue any potential benefits. The need for the identification of substandard care was emphasized. They proposed the introduction of a system of confidential inquiries into maternal deaths as a pilot study of 1 year's duration. However, after assessing the country's context, the Ministry of Health decided that it was not the right time to implement confidential inquiries into maternal deaths. Successive directors of Family Health Bureau, Dr. K.P. Vikramasuriya, 1994 to 1998, and Dr. Vinita Karunaratna, 1999 to 2008, and national program managers on maternal care gave a high priority to MDSR. The mechanism was largely restructured by Dr. Anoma Jayatilaka, national program manager on maternal care from 1995 under the guidance of Dr. Vinita Karunaratna. Their contributions were immense. During that time, participation at Colombo from the districts was thought to be not practical and was very expensive. Considering this fact, in 1995, Ministry instructed to visit the districts with a team of national level experts to conduct maternal death reviews. Reported maternal deaths were registered in a CR book maintained at FHV. In the year 2001, a computer-based maternal death database was created in MS Access. A circular on maternal death investigation procedure was sent in both Sinhala and Tamil languages. Compiling short case histories was commenced. Specific presentation formats for hospital and field were developed in consultation with SLCOG, academia, administrators and MOMCHs. Issues and recommendations captured at the NMMRs were documented. The progress of the implementation of the actions in previous minutes was presented by the MOMCH. Cause of death determination in the initial phases of MDSR was not much focused, but during this period, maternal deaths were confirmed after a consensus reaching. Assessment of preventability, family planning unmet needs, and 3 delays were objectively assessed. Postmortems were not carried out on each maternal death, but were done only for general implications. With the availability of data, detailed analysis of maternal deaths was started at the central level. Based on WHO definition, maternal deaths were classified and misclassified deaths were discarded. Dr. Deepika Artigala, as the National Program Manager, continued the MDSR process despite the challenges posed by the ongoing civil war. Maternal deaths that took place in Chetikulam refugee camp was also captured and reviewed. In 2009, Dr. Deepthi Pereira was appointed as the Director MCH. The MDSR activity was separated from the Maternal Care Unit of Family Health Bureau. She felt the need for a restructuring of the entire process and searching for a new person as the National Program Manager of the Maternal and Child Morbidity and Mortality Surveillance, a new designation at Family Health Bureau. I happened to return from my overseas training and reported to the Chetikulam refugee camp as the coordinator. I came to know that Dr. Deepika Artigala has shifted to UNICEF and her post was vacant at FHT. I met Dr. Deepthi Pereira. There is the history. Madam, can you reflect what happened?
Distinguished members at the table and also the audience. When I was invited for this oration, I was told that I had to speak a few words. I didn't know that I had to speak about how he was posted as the consultant maternal morbidity mortality surveillance as a consultant community vision. He returned from Chetikulam. He may not know that, he may not remember that I was the one who asked him to go to Chetikulam as well, because we were looking for a person to look after the antenatal mothers in the Chetikulam camp in the post-war situation. And he returned after some time. And at that time I had discussed with my Deputy Director, Dr. Chitramali De Silva, regarding the need for a more focus needed for maternal mortality, morbidity surveillance. So we were looking for a CCP, and when Dr. Kapila returned, I asked him to accept this post. He said very reluctantly, he said, no, I want something on child health. Why child health? Because I have done a lot of articles and some activities on child health, and I also have a DCH on that is the Diploma in Child Health. Well, I knew that he also has a flourishing private practice at so maybe he wanted to have a portfolio here as well on child health. No, very sorry. You will have to accept this post, as if you are to be appointed as a CCP here, you have to accept the post of maternal morbidity mortality surveillance CCP. So I can still remember his face when he walked out of the director's room. He was very angry. He was angry. And he walked out saying that, well, what to do? And he came back the following day. Yes, madam, I am prepared to accept this. I was jubilant that there was now a person. And his first maternal morbidity, mortality, the survey, that is the presentation he had to do, I can still remember, was it in Badulla? Badulla. And before the presentation, he came out with all those, the presentation he has to do with lot of new ideas, mnemonics, and some logos, which also caused some controversy among other CCPs as well. But I knew that his creativity is working, and he is working day in and out regarding this, the maternal morbidity and mortality. So you can see how this person bloomed to be the consultant maternal morbidity mortality surveillance at Family Health Bureau, and what results are that regarding his numerous orations and presentations. Thank you very much.
Thank you, madam. We undertook a comprehensive evaluation of the existing national maternal death surveillance and response mechanism at each level. Triangulation of maternal death notifications from hospital and field, and numbers indicated in routine reporting systems, RHIMS and IMMR, showed disparities and underreporting. The receipt of maternal death investigation forms was not complete, and many forms showed missing data and lacked data quality. Coverage of conducting postmortems on probable maternal death was low, and reports were not available for a substantial proportion of deaths, and there were issues in the determination of the underlying cause of death. There was a big backlog of conducting annual district level maternal death reviews by the MOH. Participation in the reviews was not satisfactory. There were issues in the modality of the proceedings of the maternal mortality. There were issues in the modality of the proceedings of maternal mortality reviews conducted. I was given full technical independence to revive the ongoing system. Dr. Deepti Perera was passionate about maternal deaths and their prevention. Starting from 2010, we further tightened the central level monitoring of the receipt of maternal death notifications, investigation reports, and receipt of postmortem reports. Each and every report was scrutinized, data gaps identified, and a system was started to collect missing data. The National Maternal Death Database was updated with data from previous years. Step-by-step comprehensive guidelines was issued on the maternal death investigation procedure. They were shared with all the relevant health institutions, professional bodies, medical undergraduate schools, and the Postgraduate Institute of Medicine. MDSR guidelines were included in the maternal care package for field healthcare workers, and it was a component in relevant in-service training programs. In 2011, conducting postmortems on maternal deaths was streamlined. We conducted several meetings with the relevant stakeholders, Secretary of Ministry of Justice, Director General of Health Services, College of Forensic Pathologists of Sri Lanka, and SLCOG, and facilitated issuing of a series of circulars and guidelines by the two ministries. They facilitated the mandatory requirement of conducting a postmortem on all probable maternal deaths, the transportation of the corpse to a specialized center, conducting the postmortem by a consultant forensic pathologist, and the timely issue of the report to Family Health Bureau. A concise format to document and report findings of the postmortems was introduced in the year 2014. Detailed maternal death autopsy guidelines were issued by the College of Forensic Pathologists of Sri Lanka in the year 2017. You see the results over the years, achieving 99% coverage. Hard copies of maternal death investigation formats were made available to Ministry of Health, MOHs and hospitals. Soft copies were uploaded to the Family Health Bureau website. From 2011, contemplating on the need of a comprehensive picture of the index case, copies of all related records, clinical records from hospitals and documents maintained at the field level were collected by Family Health Bureau. Compiling detailed case scenario for each maternal death was started in the same year. A systematic categorization of notified cases was initiated to prioritize them and obtain more details. This minimized wasting time and work on clearly non-maternal cases. It was felt the need for expertise inputs from multiple specialists for compiled case scenarios, as it was practically impossible for all categories of specialists to participate in meetings at the district level. We decided to obtain expert opinion in the modality of a desk review of selected cases of a district with the participation of representatives of SLCOG, public health specialists, and other related specialists in the year 2011. Participation of all the relevant care providers of an index case, including those from private hospitals and general practitioners, and all relevant stakeholders were made mandatory, and the notification letter of the maternal mortality review was issued under the signature of Director General of Health Services. This gave high priority to the national maternal mortality reviews and maximized participation. The format of conducting maternal mortality reviews was improved, with Family Health Bureau presenting the case scenarios in a priority order. Director, Family Health Bureau, Dr. Deepthi Pereira, decided that as the highest level MCH administrator, she should participate at each and every maternal mortality review, and she did it over all 5 years, going around the country with me and president or representative of the SLCOG. We introduced detailed minutes of the NMMR meetings with case vignettes, recommendations, and responsible persons. These minutes were disseminated to almost all officials concerned, including academia. In some cases, we went to household level to see the actual scenario. The system evolved as a mechanism enabling confidentiality assured and non-punitive system. It has ensured no name, no blame culture. The focus is on what went wrong, leading to a systems thinking perspective rather than on individual deficiencies. Details of all the maternal death cases are kept confidential and de-identified to ensure that no names of care providers involved are used during the meetings. At the same time, the official direction to participate in the reviews accomplish inculcating accountability. Due to the gross underreporting of maternal deaths in the civil death registration system, MDSR maternal mortality statistics were recognized as official data. In 2015, we suggested a special clause to capture maternal deaths in the death declaration form B33 to be filled by a medical officer confirming a death. In the same year, to facilitate the proper identification of maternal deaths from civil death registration system, the Family Health Bureau instructed field healthcare workers to send a copy of the death certificate of the dead woman. A systematic process of sharing details of confirmed maternal deaths with civil death registration system was started. We could reap a successful outcome for our efforts. Starting from 2009 to 2020, maternal death surveillance and response system achieved 99% of capture of maternal deaths from dual sources, hospital and community. We reviewed 100% of reported maternal deaths, conducted maternal mortality reviews visiting all districts every year, compiled minutes 100%, and disseminated the recommendations for action 100% over the last 12 years. To guide decision making and programming to further prevent maternal deaths, it is important to act on the findings of the death reviews. The response segment of the MDSR cycle provides a gate for countries to examine mortality data to develop and implement a targeted local and national response to prevent future deaths. Sri Lanka effectively utilized maternal mortality data for formulating and implementing targeted recommendations, the ultimate objective of the surveillance cycle. There is historical evidence going back to 1930s that the country's maternal mortality data has been utilized for advocacy in the British Parliament in the year 1935, as documented in the British Medical Journal. Mr. Malcolm MacDonald reported a comparatively high maternal mortality rate for 1933 as 18.6 per thousand births, that is 3,852 maternal deaths, and described the steps taken by the government to achieve a steady improvement. He was later appointed as the Commissioner General for Southeast Asia post in India in 1956. The Maternal Death Investigation Committee formed by the Department of Health in the year 1959 reported anemia during pregnancy as the main cause of maternal death. The government decided to admit all pregnant women with hemoglobin less than 40% to hospitals in addition to expanding antenatal and natal care given at home and clinic levels. You see how they have reported in the reports, you see, පැටලෙලි සහිත ආබාධයන්ගෙන් පෙළෙන complicated pregnancies. And in this, the anemia in pregnancy, what they have done. With the initiation of organized maternal death reviews at the national level in the 1980s, the Secretary of Health and the team visited areas of high maternal deaths to further study the causes and take on-site preventive actions. One frequently cited example is a high toll of maternal deaths reported from a rural MOH area, Moravaka, due to a shortage of staff and appointing the required cadre immediately and apparent reduction of the maternal deaths. Processes and procedures in responding to maternal deaths at the country are multiple and capitalize numerous platforms. At present, Sri Lanka translates lessons learned from maternal deaths into practice, programs and policies at different levels: community level, hospital level, district and provincial levels, national level, that is Ministry of Health and Professional Colleges. Responding to maternal deaths take place during the immediate period following a maternal death review at each level and after the completion of national maternal mortality reviews of the particular district. Immediate response to maternal deaths. The Ministry of Health decided to implement a modality immediately responding to maternal deaths from January 2018, considering the long delay in reviewing maternal deaths in the existing model. This is a face-to-face meeting chaired by DGHS and relevant ministry hierarchy, technical experts and healthcare workers directly involved in the care pathway of the index woman. Only the cases with significant issues that warrant responding immediately are selected for review. The meeting is solely a technical review in a no-fault finding framework. This facilitates effective decision making from the highest level of MOH without delay in addressing specific service deficiencies at all levels. Many meaningful outcomes were delivered out of the case reviews conducted. This modality contributed to a significant reduction, nearly 30% of maternal deaths, 128 to 89 from 2017 to 2020. Many key actions out of MDSR were executed following instructions issued by the Ministry of Health through circulars. Examples from the initial phases of MDSR include the specific circular instructions issued to make the officer in charge of a hospital responsible for conducting MCH clinics, appointing MOs to conduct clinics, and mandating obstetricians to examine all cases personally referred from the periphery in 1988. Steps were taken to minimize contamination in the labor rooms with the provision of slippers to staff and attending to broken potholes in the broken floors of the labor room in 1991. In 1993, a red sticker on the pregnancy appointment card was introduced to easily identify high-risk cases of antenatal women. Provision of transport facilities for field PHMs with 2,500 mopeds was taken place in 2006. We analyzed data and disseminated widely the outcome of maternal deaths every year with the participation of key players of maternal care. The findings were shared with the general public through media. A number of hospital level actions were undertaken, especially at Castle Street Hospitals for Women by Dr. Vimal Karandagoda. We translated lessons learned out of maternal deaths into actions. They were numerous. Examples are expediting the revision of postpartum hemorrhage guidelines, new guidelines on documenting family planning methods to needy women, the appointment of cardiologists to several specialized women hospitals, and immediate distribution of infusion pumps to needy places. Capacity building of local healthcare personnel on heart disease, dengue hemorrhagic fever management guidelines, awareness of pregnant women on influenza. With the low number of deaths, a significant proportion of maternal deaths were found to be from socially vulnerable groups. To capture difficult customers, the Register of Eligible Women in Danger, Red Book, was introduced, and this facilitated visiting her place of residence as a team and providing targeted care. With the reduction of number of maternal deaths and growing emphasis on quality of care and clinical governance, in 2016 we introduced a maternal near-miss surveillance system. In the same year, with the support from Sri Lanka College of Psychiatrists, a psychological autopsy tool for maternal suicides was introduced to gain a better understanding of maternal suicides. Outcome of the MDSR is reflected in maternal mortality indices. Between 2001 and 2020, MDSR significantly contributed to the reduction of the annual numbers of maternal deaths, 46%, 167 to 90, and national maternal mortality ratio by 37%, 46.6 to 29.2 per 100,000 live births. Professional colleges. A number of professional organizations contribute as drivers of maternal death surveillance and response. The key organizations are Sri Lanka College of Obstetricians and Gynecologists, College of Anesthesiologists, College of Forensic Pathologists, College of Community Physicians, College of Physicians, College of Administrators, Sri Lanka College of Psychiatrists, Sri Lanka College of Internal Medicine, Sri Lanka College of Cardiology, College of Transfusion Physicians, and Sri Lanka College of Pulmonologists. The stake of the Sri Lanka College of Obstetricians and Gynecologists from its inception been indispensable for the implementation and sustenance of MDSR. Starting from Dr. Vikramasuriya in 1939, several SLCOG presidents and its members contributed to maternal mortality measurement and reduction. Professor Wilfred Pereira's presidential address in 1993, Dr. Siva Chinnathambi on safe motherhood in 1997, a representative of the SLCOG was in the first Maternal Death Investigation Committee in 1959. SLCOG continued to provide expertise to maternal death surveillance. SLCOG Golden Jubilee Commemoration book, edited by Dr. Lakshman Senanayaka, records a number of contributions made by the college in maternal mortality reduction and surveillance. Dr. Lakshman Senanayaka is here. Can you tell us a little bit, sir?
Thank you, Kapila. Now that I have got hold of the mic, let me make one small clarification. I am Dr. Lakshman Senanayaka, correct, but I am not the president of the College of Obstetricians and Gynecologists. Just a clarification. I am here as your friend. From the inception, I think to answer your question, from the inception, Sri Lanka College of Obstetricians, which started as an association, their primary objective was reduction of maternal mortality and nothing else. So the group got together. I think Professor Ranasinghe, out of the people that we can remember, at least we knew of, Professor Ranasinghe was one of the founder members. Professor Wilfred Perra is a founder member. And their main target was reduction of maternal mortality. As time went on, the college expanded its services or the work, but it never forgot the role of being the main how shall I say, flag bearer for maternal mortality, reducing maternal deaths. I think the first editorial of the first journal, first publication, first says this organization was established for the only reason for reducing maternal deaths in this country. And it is not a trade union. I think that was a statement, very categorical statement made. I think all the people from then onwards, now that you are talking about history, you can see people like Professor Kingsley Silva, who had drawn all the charts and tables with hand. I think you would have seen some of those publications in the SLMA downstairs. And they have taken so much of trouble to address this issue. And as went along, Dr. Nalin Rodrigo, I think one of the stalwarts who was pushing this maternal deaths and the survey, I think you were talking about Prasanna, and I was involved to some extent, but was led by Dr. Nalin Rodrigo and Dr. Lakshman Fernando. So basically, the college took it to their hand, the main role, and at that time, the government involvement was as you described. Consultant community physicians, sort of as a group of specialists, didn't exist at that time. So basically, the weight was taken by the obstetricians and the college. But as time went on, the college realized that the importance of working with other people, and I think Professor Harshadhan Viratna, one of the earliest people who worked with the Family Health Bureau in this maternal death review, I think he virtually single-handed did that. Later on, he included people like us and other people, Ajita and them laterally. So it sort of became a combined thing as it went on. So I think the answer to your question is yes, the college has taken this as a major thing and had done whatever the contribution, not only in reviews, but in capacity building, helping them to provide standards, all that kind of thing was done. I think that's the answer that I would like to give you.
Thank you very much, sir. The memorandum on addressing maternal mortality developed to guide policy of Ministry of Health in 1989. This was prepared by Sri Lanka College of Obstetricians and Gynecologists. As Sir mentioned, Professor Harsha Senaraj was involved in the pioneering work in putting the systems into work. He was a key resource person at national level activities. Many of the presidents of SLCOG actively participated at the National Maternal Mortality Reviews throughout the country. the establishment of a maternal mortality committee at SLCOG showcased the assumed leadership and ownership of the obstetricians in the MDSR process. It has been the standard practice that the President SLCOG to participate at all maternal mortality reviews throughout the year. Its members serve as reviewers in all formats of reviews on an honorary basis. Dr. Ajitha Vijayasundara represented SLCOG at district level maternal death reviews consecutively for 9 years, sacrificing his time and work. Where is Sir?
What do you want me to say?
Yeah. You were traveling with us all the way 9 years.
I know, taking a lot of my valuable time from 2010, I think, to 2020 till the COVID epidemic broke out. During this period, as a member of the SLCOG, I visited the Family Health Bureau and must have gone through well over 1,000 maternal deaths where we reviewed with my colleagues like Dr. Lakshman, Dr. Ratnasiri, and many others. And then we went out to all 26 health districts. And we visited Jaffna more than 6 times, Trincomalee. And I know, as was mentioned, Kapila had a good practice. So he said, sir, we'll go by plane to cut down on the time, you know. Jaffna took about 3 days, you know. So that we did at our own expense. Trinco, Ampara, and Jaffna. Anyway, it was very interesting. And during that period of 2010 to 2020, I think the maternal mortality rate came down from 39 to 29. And I don't know, there were about 60 mothers that died during the COVID epidemic. So I don't know how the figures are now. Anyway, I have to congratulate you on a wonderful bit of work that you have done in compilation of all these statistics and a wonderful oration. Congratulations. Thank you.
Yeah. Thank you, sir. When the system was not performing as expected, several presidents of the SLCOG, namely Professors Hemantha Senanayaka, Kapila Gunawardena, and Sanath Lanroy, went out of their way to put the mechanism on the right track. UNICEF provided funding support to FHB for conducting maternal death reviews continuously until mid-2010, when the Ministry of Health started to fund the program. WHO also provided both technical and financial support. In 1992, WHO supported a visit by 2 consultants from WHO and UK to explore the establishment of a pilot national system for the confidential inquiry into maternal deaths. WHO also supported Family Health Bureau to study confidential inquiries into maternal death in UK for director and national program manager in charge. Successive national program managers and nominees from SLCOG were also provided with training on MDSR by WHO. UNFPA is also supporting to streamline MDSR process. Sri Lanka records a successful story in implementing MPDSR over the last 7 decades. Data-driven culture established by the colonial rule from the late 19th century laid the foundation for the availability of accurate data on the number of live births and counting maternal deaths through routine death registration. This is complemented by reliable health information systems originating from household and hospital levels. The MDSR system was started and continued as a government-owned process with the engagement of the highest level health officials. The MDSR was initially commenced as a public health activity, capitalizing on the high level of orientation on the prevention perspective. The positive attitude of the professional bodies and the committed curative health staff were plus points. The timely introduction of a number of reforms to the process with the addition of innovative quality dimensions has allowed the system to evolve as a role model for other countries. The success was phenomenal even in 1990s, as reported in the Lancet by Dr. P.C. Gunasekar and Professor P.S. Vijay Singh. British Journal of Obstetrics and Gynecology, BJOG, described it as the best organized and structured system. This is how Al Jazeera reported. In WHO's latest publication on maternal mortality measurement, guidance to improve national reporting, Sri Lanka's system is described as a role model mechanism. It was clearly a team effort. There are so many contributors to maternal death surveillance in Sri Lanka, whose efforts and names will never be told or documented in the history of medicine. I can only jot down a few of them whom I know over the last few decades. There may have been so many. Their work had been indispensable in the pathway of MDSR evolution in the country. Ajit?
Sayana. Sir Hamadam Ahmada, Dedas Ekola Sresita, Dedas Mistuna Medaka, Basara Dorak, Puravata, Matru Marna, Samalochana Vedastan Sanda, Pasabagina, Esanda Page, Mata on the Deni Matina, Mekatu Mokada Karan, Merate Abur Devenuing, Esanda Page, Samna, Daikate Malabadina. I think me Lipigono Tibano, Suraksita, Araksa Kraganimi, Raksiba, Rakaganimi. කටයුතු කරන්න අපි හැම විටම කටයුතු කරනවා. ඒ වගේම ඉදිරියේදී විශේෂඥ වෛද්‍යවරුන් විසින් ගන්නා වූ සියලුම කර්තව්‍යයන් වලට නොප්‍රියලා දායකත්වය ලබා දීමට මා කටයුතු කරන බව කියමින් නිහඬ වෙනවා. ස්තුතියි.
I am sorry, I have to be little deviated from the norm because these people will never be acknowledged. If they haven't been there, so our system would have not been like this. We need to reach to the peripheral level safely, comfortably, and without waste of time. Their insight and commitment to the program had been crucial. Just think, if we did not get their support, I feel this is not fair. That is why I thought of to be little eccentric today. There are a lot of professionals, organizations and colleagues who need to be acknowledged. If I mention each one of them by name, I will be in trouble. My gratitude goes to each and every one of them who contributed to the evolution of the MDSR in Sri Lanka and helped me in making this oration a success. I thank you all for accepting our invitation and listening to my oration. My parents paved the way for me to become who I am today. I always remember all my teachers from grade 1 till today. They are my strength. They made my life easy. I will leave this piece of paper found tied onto a cheetah of a dead pregnant mother to eternally echo in your mind. Thank you.
Dear sir, it was quite a phenomenal session of knowledge sharing. And ladies and gentlemen, doesn't he deserve another round of applause? Thank you. With that, we now conclude the proceedings for this evening. On behalf of the President and Council of Sri Lanka Medical Association, I wish to inform you that all of you are invited for the reception that will follow. Thank you and enjoy the delicious dinner which awaits outside the auditorium. Good night, take care, and ladies and gentlemen, please rise as the ceremonial procession will now leave the hall.